arthritis, where the deposition of crystals in articular structures may lead to symptomatic disease. As you know, there are monosodium urate and calcium pyrophosphate crystals, which causes crystal deposition arthropathies, which we will discuss more as the lecture goes on. Then you have infectious arthropathies, arthritis, which the synovium may become the seat of acute or chronic infection related to bacterial, fungal, or viral organisms. The cardinal pathologic findings include intense infiltration of neutrophils, which result in necrosis of synovium and formation of granulation scar tissue. So you get a dense fibrin infiltration by neutrophils forms over the surface of the synovium. Then finally you have structural or mechanical joint derangements like previous trauma, congenital developmental alterations, alterations of subchondral bone, alterations of supporting structures, cartilage derangements, host factors including the following: genetic trails, obesity, occupation, which of course lead to osteoarthritis. That's the kind which I want to highlight here. So I just gave a background of this knowledge for you to go to the problem-based learning. So when you see a patient with polyarthritis, of course you have to take a complete history and examination. Then you have to get a history of trauma. Then usually we do plain films, that is X-rays, and obtain full blood count and ESR and uric acid. Of course, sometimes this joint pain can be due to a fracture. Then you can detect that from your X-ray films. Then you can also appreciate joint effusions. Then if there is a joint effusion, we usually go for an arthrocentesis. And you get the synovial fluid, and based on the synovial fluid, you can diagnose the different etiologies of different arthritis. Like if you can detect crystals, it will be a crystal deposition arthritis. Then depending on the white cell count, you will diagnose the non-inflammatory, inflammatory, and septic arthritis, occult fractures, and fractures. So this algorithm shows you a clinical approach to diagnosing arthritis. We come to problem-based learning. You can unmute, and you can expect some answers from students. This is a 23-year-old male was admitted with fever and swollen knee joint. Complaint of shortness of breath and chest pain. Following admission, his fever continued, and the investigations are as follows. Full blood count shows the neutrophil leukocytosis, white cell count of 21,000, ESR of 50. The renal functions are normal. Chest X-ray showed mild cardiomegaly. Rheumatoid factor is negative. ANA is negative. So what is the possible differential diagnosis you would like to present, or one, or at least one or two diagnoses or three diagnoses? You can interact and give me. Anyone would like to give a differential diagnosis or a single diagnosis?
Septic arthritis, sir?
Yeah, septic arthritis is one diagnosis, yes. Any other possibilities? Yeah, of course, when a patient is coming with fever and arthritis, septic arthritis is high. Any other possibilities? Yeah, usually you don't get neutrophil leukocytosis in this condition. When it comes to septic arthritis, we have the bacterial arthritis and the gonococcal arthritis. Both are correct, but can somebody mention a condition which is not infective? Any non-infective cause anybody can mention? Well, the other differential diagnosis that goes close with is adult onset, what you call as juvenile chronic arthritis or Still's disease, which is matching with this presentation. So, if there is fever with arthritis, you will consider infections, reactive arthritis, writer's syndrome, systemic onset juvenile chronic arthritis, Kawasaki disease, polyarthritis nodosa, malignancy, ALL, and neuroblastoma. These are the latter causes are not so important. But if there is no fever, then it's the arthritis on the right side of this algo. You can see, but when there is fever and arthritis, it's either infection and the other non-infective causes I have shown here. The commonly reactive arthritis and juvenile chronic arthritis or Still's disease. Writer's syndrome is also a form of reactive arthritis. So what is the most likely here? There is involvement of serosa here, like this patient, if you go back on the history, the patient has neutrophil leukocytosis. There is a high ESR. There is cardiomegaly. So cardiomegaly, when you see a cardiomegaly, you have to suspect whether there's myocardial involvement or pericardial involvement. So probably there is a pericardial involvement matching with the history. And all the rheumatoid factor and ANA is negative. So he basically is having a serositis with neutrophil leukocytosis and a high ESR. So the overall clinical picture is more in favor of Still's disease. So there are some criteria here to diagnose Still's disease, like fever of 39 lasting for more than 1 week, the arthralgia or arthritis lasting more than 2 weeks, typical non-pruritic salmon-colored rash, a leukocytosis of more than 10,000. Then they also have sore throat, lymphadenopathy, splenomegaly, abnormal liver function tests, and classically rheumatoid factor and ANA is negative. You have to exclude other causes of arthritis like infections, very especially septic arthritis, malignancy, and other rheumatic diseases. So if there is more than 5 criteria, that is a definitive diagnosis. So that is called this Yamaguchi criteria. I don't think you have to know extensively, but what you have to realize is that in a patient who is having a fever, neutrophil leukocytosis, high ESR with poly or oligoarthritis, one of the leading diagnoses you have to consider is Still's disease. Then you can apply the criteria for definitive diagnosis. Serum ferritin is not in the diagnosis criteria, but usually it is high in this condition. And the ultrasound abdomen, usually we do to for lymphadenopathy and hepatosplenomegaly. And as you said, classically the liver functions at a range. So in this patient, you have to request these investigations in addition. So the treatment is, as you know, non-steroidal anti-inflammatory drug, steroids, methotrexate, and certain biological agents. So those are the definitive treatments. So this is how you go by algorithm. Of course, confirmed adult onset Still's disease. First line will be NSAIDs, corticosteroids. The patient is very severe, you can use intravenous immunoglobulins. And if they become corticosteroid dependent, then you'll have to tail off corticosteroids by adding methotrexate and If there is no sufficient clinical response, then you go for these biological agents. If there is pregnancy, of course, we have to use only corticosteroids and intravenous immunoglobulins. So that this tries to give the overall picture of how you manage general chronic arthritis. With that, we go to the next illustration. A 33-year-old female patient presented with swelling of small joints in the hand. Joints are stiff in the morning, and it takes 1 hour to mobilize herself in the morning. There is no fever. On examination, she is pale and has polyarthritis. Cardiovascular and the respiratory examinations are normal. What is the differential diagnosis you will consider? I hope you can answer. This is a very easy question. Yeah, so there is very one of the leading possibilities. Any other? Yes.
So gout.
Gout is what gout? Yeah, usually common gout is monoarticular, but then this has to be a polyarticular tophaceous gout. Any other condition that is usually associated with dermatological manifestation? Psoriatic arthritis. Yes. So it's a wide DD here. As you said, it's basically a differential diagnosis of polyarthritis. Inflammatory because the patient is having morning sickness here, so rheumatoid, SLE, gout, pseudogout, and then of course arthritis, sacroiliitis, they come low down on the list. Gonococcal arthritis, viral arthritis, subacute bacterial endocarditis, psoriatic arthritis, scleroderma, all come down low on the list. Of course, you can get polyarthritis, non-inflammatory, which is osteoarthritis. We call it nodal osteoarthritis, amyloidosis, and hypertrophic pulmonary osteoarthropathy. These are just non-inflammatory conditions. The whole list, I just put it from the textbook. You can read it, but I think what you have to take is the major common things are common, and you can't tell all the possibilities at once. So rheumatoid arthritis, SLE, gout, and psoriatic arthritis comes high on the list here. So, but most likely with the history of the patient, a 33-year-old young female, and all the features are in favor of the commonest diagnosis here would be rheumatoid arthritis. So, what investigations you should request here? I hope if you can tell 1, 2, 3, 4, 5.
So rheumatoid factor.
Yes, rheumatoid factor is positive in about 80% of cases. But 5% of normal individuals, when it appears in patients with arthritic pain on both sides of the body, it is a strong indicator of rheumatoid arthritis. You can get 20% of patients with seronegative rheumatoid arthritis. Then for ESR, as you know, CRP is high in severe rheumatoid arthritis. So by seeing a CRP, you can't diagnose septic arthritis. Sometimes people, when they see a very high CRP, they think it's only infections. Then this test called anti-CCP antibody test, which is very specific for rheumatoid arthritis, can identify rheumatoid arthritis years before the symptoms develop. Of course, you have to look for complications like anemia and also sometimes X-rays, which will help you to identify joint erosions. These are the tests you will request. Then we are asking for non-articular manifestations, or so-called complications of rheumatoid arthritis. It's all textbook stuff, of course, you can know, but since we have asked question, you can get rheumatoid nodules, Reynolds phenomenon, palmar erythema, leukocytoclastic vasculitis, pleuropulmonary like pleuritis, pleurodeficiency, red lung nodules, eyes, scleritis, episcleritis, keratoconjunctivitis. The cardiovascular manifestations, basically atherosclerosis, myocardial infarction, and pericarditis. Neurological manifestations may interrupt neuropathies like carpal tunnel syndrome and mononeuritis multiplex. There are osteoporotic changes and tendon and ligament ruptures. And kidney, you can get the glomerulonephritis and Pelti's syndrome and vasculitis. So if you look at diagnosis here, I'm sorry, this is very small letters. Uh, we have to do X-ray usually to see whether there are early joint erosions. If there is no erosions, we know it's a mild disease, and then we can treat with hydroxychloroquine sulfate or minocycline, but we use usually is chloroquine. But then if there is a severe disease, which means the early erosions are seen, then you have to start disease-modifying drugs immediately with methotrexate and go ahead with methotrexate. That's the normal treatment for rheumatoid arthritis. So, as you know, in pregnancy, methotrexate and leflunomide is contraindicated, whereas sulfasalazine, steroids, hydroxychloroquine, and NSAIDs can be used. In lactation, you are contraindicated cyclosporine and can use gold salts. In liver disease, you can't use methotrexate, leflunomide, non-steroidal anti-inflammatory drugs, and sulfasalazine. So, if you have a liver disease, you have to manage them with HCQS and gold salts. If you have renal disease, again, NSAIDs, methotrexate, and gold salts are contraindicated. So, you have to manage with HCQS and sulfasalazine. In lung disease, methotrexate generally we don't give because of the risk of pulmonary fibrosis. So those patients should be managed on leflunomide, HCQS, and sulfasalazine. So you can see when you consider this history, it's a young female with potential pregnancy. What drug will you start if you look at this? What is your preferred anti-rheumatic drug here?
Hydroxychloroquine, sir.
Yes, and what is the other disease-modifying drug? Steroid. Yeah, steroids we can use, hydroxychloroquine we can use, and sulfasalazine. Sulfasalazine is the other indicated drug. Corticosteroids in rheumatoid arthritis is corticosteroids, both systemic and intra-articular, are important adjuncts in the management of rheumatoid arthritis. Indications for systemic steroids are for treatment of rheumatoid flares, for extra-articular rheumatoid arthritis like rheumatoid vasculitis and interstitial lung disease, as bridge therapy for 6 to 8 weeks before the action of DMARDs begin. Maintenance dose of 10 milligrams or less of prednisolone daily in patients with persistent active rheumatoid arthritis, sometimes in pregnancy when the DMRDs cannot be used. So this is where you use corticosteroids. Hope we got some idea of I think, more of the MCQ-oriented questions I try to cover. Then next illustration is a 60-year-old gentleman was admitted with acute swelling of right, some problem in the slide. Right metatarsobophalangeal joint, first metatarsobophalangeal joint. He had severe pain. There was no history of fever. He gives a past history of joint pain in the left foot, but this has resolved and no further investigations done. He takes alcohol regularly. So it's a sudden onset monoarthritis involving the right metatarsophalangeal joint, first metatarsophalangeal joint. What is the most likely diagnosis? I think so easy illustration. You should be able to give the most likely diagnosis.
Acute gout.
Septic arthritis.
Yeah, acute gout. The other diagnosis also came the septic arthritis. Yes. Then the next question is, how would you investigate? How would you treat the most likely diagnosis? So acute monoarthritis. So septic arthritis always you have to consider. Reactive arthritis like GI infections which causes Campylobacter, Salmonella, Shigella, Yersinia. Genitourinary infections like chlamydia. And then we have crystal arthritis, which is gout and pseudogout, and hemarthrosis. That's the DD here. So most likely, of course, gout because of the classical joint involvement. So how do you diagnose gout when you don't do synovial fluid analysis? Of course, in your clinical practice, you don't do, in our setup, we generally don't aspirate these joints. If it's male, there's a high chance. Previous patient reported arthritis attacks. Onset within 1 day, that is, comes very sudden, and the joint is usually red. Involvement of the first metatarsophalangeal joint, hypertension and other cardiovascular diseases, and a high serum uric acid level of 5.88, which is 350 micromoles per liter. And that is an indication that this patient is having gout. The bottom there is a scoring system. I don't think you'll be really bothered about that. But if you see these features, this becomes the high priority diagnosis on the list. Now, I just want to show you this, like we do synovial fluid analysis, and as you know, in the synovial membrane, the inflammation is usually lymphocytic infiltration, like lymphocytic, but like lymphocytic. But the lymphocytes do not migrate into the synovial fluid. So what you can see in the synovial fluid is more like what you get in synovial fluid is neutrophils. So with the normal synovial fluid, it's colorless, clear, and you only see less than 150 neutrophils. In non-inflammatory arthritis, also you get some neutrophils. You get about 3,000 neutrophils. Septic arthritis, you get more than 50,000 neutrophils. Hemogenic arthritis, you see blood cells. So from the look of the synovial fluid, you come to diagnosis. Normal viscosity is high, clarity is clear, and it's a colorless straw solution. In non-inflammatory, usually you see the viscosity are high, clarity is clear, it's a straw yellow, but you see whites a count of about 3,000. Inflammatory arthritis is cloudy, yellow, more than 30,000. But septic, of course, it's mixed, opaque, and it's pus looking, and you see a count of more than 50,000. So that's how you analyze the synovial fluid. So this is different. Sorry? Yeah, you can ask. Yeah. No, if you aspirate a normal joint, you won't get more than 3.5 ml because it's a very small volume you have. Yeah. That is, if you have inflammation only, there is synovial fluid accumulation. You understand what I'm saying? If you aspirate a normal joint, you only get a very small amount of fluid. That's the answer to that. Yeah. So osteoarthritis, if I go different kinds of arthritis, the osteoarthritis color is yellow, clarity is clear, white cells are about 700, like polymorphs about 15%. The traumatic arthritis, you get a straw-colored, cloudy white cell count of about 1,000 crystals you don't see. SLE, straw-colored, clear. There is inflammation, so there will be a higher number of neutrophils, like 20,000. Sorry, 2,000. And rheumatoid, it's about 14,000. Pseudo-gout, about 15,000 neutrophils. And gout and rheumatoid arthritis usually about 20,000. The infections like septic arthritis will have very high neutrophil counts, like 90,000. These are just rough estimates, but you can see that by seeing few neutrophils, you should not get excited, like unless you see pus with 90,000 neutrophils, then it becomes septic arthritis. Even in TB, you get some neutrophils. That's what you have to keep in mind. So treatment here is NSAIDs. We have to be careful with the renal insufficiency. And then colchicine, if NSAIDs are contraindicated, but the problem you can get diarrhea and bone marrow suppression. Steroids, that's the acute treatment. The acute phase, we don't give allopurinol or febuxonide. Then of course, modify the risk factors like stopping alcohol and stop thiazide, diuretics, and obesity. Then you can use uricosuric drugs like probenecide or xanthine oxidase inhibitors, febuxostat and allopurinol. Allopurinol is what we are more familiar with. So that's the treatment of gout, but that is usually used after joint inflammation subsides. Once joint inflammation has gone down, ESR has come down. In about 2 weeks' time, we will start these xanthine oxidase inhibitors. So comes to the next illustration. A 35-year-old gentleman presented with acute back pain. He has returned from Thailand recently after a brief holiday. He had diarrhea for a couple of days. This was treated by a GP. On examination, he has spinal tenderness. It's mainly on the lower spine. What is your differential diagnosis? How would you investigate? What complications would you expect long-term, and outline the management? So what is the most likely differential diagnosis here?
Reactive arthritis.
Yeah, reactive arthritis. And in that case, what part of the spine is involved? He's having a low back pain, but what part of the spine? Like you have intervertebral joints or facet joints, sacroiliac joints. What is involved? Yeah. In reactive arthritis, what is involved is sacroiliac joints usually. Okay. You know, when you see a patient coming with back pain or a nerve root problem, you have something called red flag signs. If it is in a young patient of less than 20 years or 55 years, that itself is a red flag sign. If there is a non-mechanical pain unrelated to time and activity, thoracic pain, and previous history of carcinoma, steroids, HIV, feeling unwell, weight loss, widespread neurological symptoms, and structural spinal deformities. So if there is indications for nerve root problems, inverted leg pain, radiates to the foot or toes, numbness and paresthesia in the same distribution, straight leg raising test induce more leg pain and localized neurological signs. So most likely in this case is Reiter's syndrome because this is following a diarrhea. That's the most likely diagnosis. So when you say causes of sacroiliitis can be, you can get from this synonym pair, P-A-I-R, is pneumatic, pneumonic. P is thoracic arthritis, A is ankylosing spondylitis, I is inflammatory bowel disease. R is reactive arthritis like arthritis syndrome. Actually, P and R is further apart. Are the asymmetric causes, and A and B are together. So that means they're symmetrical usually. So this is a synonym for you to remember in your questions. So as you know, writer's syndrome is a combination of conjunctivitis. They also have plantar fasciitis, keratoderma, blenurgia, secondary balanitis, urethritis, and asymmetrical oligoarthritis. Treatment is usually we treat with antibiotics because there is an underlying infection. Non-steroidal anti-inflammatory drugs settle the inflammation and treat the pain. Corticosteroids may be used topically, intra-articularly, and systemically. Disease-modifying anti-tumoral drugs may be used in its states are ineffective and contraindicated. So that concludes the illustrations and this topic of swollen joint. Any questions?
Excuse me, sir.
Yes.
So if suspecting of septic arthritis, sir, should
Yeah.
synovial fluid aspiration done before giving empirical antibiotics?
No. Actually, sometimes usually we do synovial fluid aspiration under sterile conditions in a theater, no, for septic arthritis. Sometimes we do arthrotomy also. What is the first investigation that you should do is a blood culture. So you first do a blood culture and start antibiotics and subsequently do the synovial fluid aspiration. So first investigation to do is blood culture.
Okay, sir. Thank you, sir.
Any other queries? Can you get these slides? You can't. You can't download from here. Okay, then see you later next week most probably. So can we conclude the discussion? Okay. I think this record, yeah. Okay then. So I'm exiting in the absence of questions, right?